All right, can everyone hear me? All right, good. So thank you very much for the invitation to give this talk. I'm sorry I wasn't able to make it in person, but I'm hoping that the technology works and that everyone can hear things clearly. Mike will let me know if you can't. So I was asked to talk today about clinical trials, which are obviously a very important thing that we do to help advance the field and to help discover new drugs. And as patients, your participation in clinical trials is critically important. So I'm going to start with some very basic definitions that will be helpful as we go through this presentation. When it comes to clinical trials, there's a certain language that we use. We talk about response rates, which refers to the amount of shrinkage or the percentage of patients with significant tumor shrinkage on scans. And we define that as greater than 30% shrinkage of tumor as a partial response. Complete response, which is very rarely seen, is complete disappearance of the cancer. And then stable disease means no response, but also no progression. Progression-free survival refers to the amount of time until tumors grow significantly, which we define as greater than 20%, or if new tumors develop. Median progression-free survival refers to the duration of time until half patients in a study have progressed. In other words, the average amount of time until progression. Overall survival, OS, is self-explanatory. The hazard ratio is the comparison of two survival groups in a randomized clinical trial. Hazard ratio of 1 means there's no difference between the groups. Less than 1 means that there's improved progression-free survival or overall survival. And p-value refers to the statistical significance, the chance that a positive result of a trial isn't due to chance. And typically we define that a positive trial is less than 5% odds that it's purely due to chance. We have several types of clinical trials, several categories. Phase 1 clinical trials, which I'm sure many of you have heard of, are the first in human studies. They're studies of drugs that have shown some activity in animal studies or preclinical studies and are being tested for the first time in humans, typically to find the optimal dose to be able to investigate in future clinical studies. So the primary purpose of the phase 1 study is to find what kind of dose can patients tolerate. Phase 2 study is typically, but not always, a single-arm study with the primary endpoint of trying to figure out what the efficacy of the study. And often it's response rate, amount of tumor shrinkage, or progression-free survival. Phase 3 is typically a large randomized clinical study that's designed to lead to approval of a new drug. And it's comparing the new drug either to a standard of care or a placebo. Typically, a phase 3 study, but not always, is double-blind, meaning neither the doctor nor the patient knows which study is being administered. And patients sometimes ask, why do we need placebo-controlled studies? Well, this is often the cleanest way of finding whether a study drug really works. It's often appropriate when there's no standard of care option, meaning patients have progressed through all the standard of care treatments and now are being offered a drug where there is no standard of care. And many studies also allow crossover from placebo to the trial drug if they progress on placebo. Now, an important caveat is that comparison between clinical trials is different. Trials have different populations, different eligibility criteria, sometimes different response criteria. So just because one study shows, say, a median progression-free survival of 1 year and another shows a progression-free survival of 1.5 years, doesn't at all mean that drug B is better than drug A. They're completely different studies. So it's important to keep that into account. So I'm going to move on now to discuss specific drugs that are being studied in the neuroendocrine tumor space. And one category is the so-called targeted drugs that target specific receptors on cell surface. It doesn't necessarily mean that they're targeted to unique features of neuroendocrine tumors. In fact, none of these drugs are unique to neuroendocrine tumors. But then, unlike traditional chemotherapy, they don't just target cell division, they target receptors on the cell surface. And these particular drugs fall into a category called tyrosine kinase inhibitors. They target a particular part of a receptor. Some of these new drugs include Lenvatinib, Cabozantinib, Axitinib, and Surufatinib, and they all target the vascular endothelial growth factor receptor. The so-called VEGF receptor is involved in angiogenesis, development of new blood vessels to tumors. Tumors need growth of blood vessels to progress and grow. And so these all target that, and some of them target other receptors, either on blood vessel cells or on the cell surface. Now, we already have one tyrosine kinase inhibitor already approved. It's Sunitinib. Some of you may be familiar with it. It's approved for pancreatic neuroendocrine tumors. This study in 2011 demonstrated that it significantly prolonged progression-free survival compared to placebo, leading to its approval. The response rate was quite low. It was less than 10%, but it tended to stabilize tumors, which was what led to its approval. And of course, it does have many adverse events, which can be sometimes quite problematic. There's another drug called Pazopanib that was recently studied in a smaller randomized phase 2 study, also compared to placebo. It's also associated with a very low response rate, a very low rate of tumor shrinkage, but it does stabilize disease, and in this case, it improved the median progression-free survival from 8 months to 11 months. Now, you might ask, is that enough for approval of the drug or enough to recommend it on guidelines? And the answer is probably no. It's a relatively small trial. It was a little over 100 patients. It hasn't yet been endorsed by several guideline organizations. I think there's a desire to see larger clinical trials before this drug becomes approved. But it was the first drug to show, and angiogenesis inhibitor, to show activity in gastrointestinal and lung nets, as opposed to Sunitinib, which was approved for pancreatic neuroendocrine tumors. Now, Lenvatinib is a similar drug. It targets this angiogenesis process, new blood vessel growth of tumors, but it also targets other receptors on the cell surface. It's approved for several other cancers, including recently liver cancer. But it was tested in a single-arm phase 2 study, a large study that took place in Spain, 111 patients, all with progressive disease, mostly heavily pretreated patients, about half with pancreatic nets and half with gastrointestinal nets. And despite having received lots of other treatments, 40% of the pancreatic neuroendocrine tumors showed a significant response, significant tumor shrinkage. That's an extraordinarily large percentage of response for one of these targeted agents, much higher than what we've seen with other similar drugs like Sunitinib. And the response rate was 18% in gastrointestinal neuroendocrine tumors. The median progression-free survival, in other words, the median time to tumor growth, was relatively long, more than a year for both populations. The side effects are similar to Sunitinib, sometimes can be quite difficult. This drug is manufactured by a company called Eisai. We were hoping that they would be looking favorably at a large phase 3 study based on this data. So far, they haven't. So unclear whether this drug is going to move on to larger clinical trials in the neuroendocrine tumor space, which it would be great if it could, because this phase 2 data is better than what we've seen with other similar drugs. Cabozantinib is another tyrosine kinase inhibitor. A phase 2 study in Dana-Farber showed response rates of 15% in pancreatic neuroendocrine tumors and 15% in gastrointestinal lung neuroendocrine tumors with progressive disease. And the median progression-free survival, again, median time to tumor growth, was relatively long, roughly 2 to 2.5 years. And so that's led to the phase 3 CABINET trial. It's a so-called cooperative group trial. It's taking place across the United States, including at Moffitt and probably other centers in Florida. The eligibility criteria right now are for gastrointestinal and lung neuroendocrine tumors, not pancreatic neuroendocrine tumors, who have received prior everolimus, Afinitor. But the study is being amended now to remove that criteria so that patients who have not yet received Afinitor will be able to enroll. Again, it's a randomized phase 3 clinical trial. So half the patients will get Cabozantinib, half will get placebo. Right now, there's no crossover, but the study is being amended to allow placebo patients to cross over to Cabozantinib. So hopefully that'll happen soon. Very important study. It's enrolled about 40 patients so far, a little bit slowly, but we're hoping to pick that up. And if it's a positive study, which it probably will be, we'll hopefully have another drug to offer patients. There's a drug called Surufatinib. Again, it's one of these tyrosine kinase inhibitors. It was studied thus far in neuroendocrine tumors exclusively in China. And in a phase 2 study, it showed response rates of about 10% and a relatively long duration of progression-free survival. And so that's led to 2 phase 3 studies of Surufatinib, one in GI and gastrointestinal and lung neuroendocrine tumors, progressing, no more than 2 prior treatments, and they were randomized to Surufatinib versus placebo. And the results were just presented a few months ago. You can see this was a relatively aggressive patient population. In other words, the cancer was aggressive. The median time to progression on placebo was less than 4 months, but it was more than 9 months with Surufatinib. So that was a big difference, highly statistically significant, showing that the drug worked very well. And the response rates were 13% with the drug versus 0% with placebo. There's a parallel study taking place in pancreatic neuroendocrine tumors that the results have not been presented yet. So the bottom line is this study is looking very favorable, but right now so far exclusively in a Chinese population. And I think probably the FDA will require a duplicate study in the West, in other words, North America and Europe, in order to lead to approval here in the United States. But we'll see if that really is a requirement, and if it is, hopefully we'll be able to complete the study relatively quickly. The last tyrosine kinase inhibitor I want to mention is Axitinib. This purely targets this vascular endothelial growth factor receptor, in other words, blood vessel growth. We did a study at Moffitt and the University of California in San Francisco showing a fairly long progression-free survival with this drug. And currently there's a study taking place in Europe, primarily in Spain, a phase 3 study in gastrointestinal and lung nets comparing Axitinib versus placebo. And so we're expecting results of this study probably next year. And if it's positive, hopefully approval in the United States and Europe for this relatively new tyrosine kinase inhibitor. It does have side effects. It can cause, like all of them, high blood pressure. It can slightly increase the risk of heart attack or stroke, sometimes diarrhea, tiredness. But we're hoping that it shows benefit. So that covers this category of drug called tyrosine kinase inhibitors. Now, another category of clinical trial is drugs that compare not to placebo, but rather to active drugs. We haven't had much of that. Actually, we haven't had really almost any of that in the neuroendocrine tumor space. Most of our trials have compared drugs to placebo. But there are currently several that are comparing to active treatments. And one of the most important ones is the COMPETE study. This is a trial that's looking at Lu-edotreotide. Another way of saying that is lutetium dotatalk. It's a type of peptide receptor radiotherapy that's very similar to the currently approved drug Lutathera. And it's comparing it to everolimus, Afinitor, a drug that many of you are familiar with and many of you have been on. It's a 2-to-1 randomization, so there's twice the chance of being randomized to the radioactive drug versus the Afinitor. And the question is really which drug prolongs time to progression more. In other words, it's asking which is the better drug, balancing safety and toxicity. So a very important trial. It's accruing relatively slowly. You know, when it comes to this kind of trial, patients might ask, what is the benefit to me? What is the benefit to the patient of accruing to the trial when I can get basically both of these drugs as standard of care? And the answer really is that it benefits the field. It allows us to really compare two drugs, compare the risk and benefit, and allow us to figure out how to better treat patients. There's another trial taking place in Europe. Actually, I think it's almost completed enrollment that's looking at an old chemotherapy drug, streptozotocin and 5-fluorouracil, compared to everolimus, Afinitor, and looking at how to best sequence these drugs. And again, this will give us some sense of in pancreatic NETs, where we have several treatment options, including these two, what the best way of approaching patients with metastatic disease, how to sequence these treatments. So that's an important trial. For patients with high-grade neuroendocrine tumors, where we almost have no clinical trials, there's a national trial run by the ECOG cooperative group comparing a standard older regimen, cisplatin or carboplatin with etoposide, intravenous chemo regimen versus an oral chemo regimen, capecitabine temozolomide. This is another important study, but one that's not easy for patients to get on necessarily, because most patients start chemotherapy in the community before they get to an academic center where this clinical trial might be available. So switching topics, immunotherapy is a category of treatment that has generated a lot of excitement in cancer. It basically stimulates the existing immune system, lymphocytes, to target cancer cells. You know, the cancer cells are smart. They can express certain ligands, which are proteins on a cell surface that block the action of T lymphocytes and prevent the T lymphocytes from targeting the cells. One of these ligands is called CTLA4, another is called PD-L1, and we have drugs that target both of these and basically block this negative interaction between the cancer cell and the lymphocyte, and allow the lymphocyte to target the cell. This approach has worked quite well in certain cancers like melanoma or lung cancer, where cells have developed a huge amount of mutations. They express a huge amount of abnormal proteins on the surface that the lymphocytes can target. And so in certain cancers, it works quite well. In neuroendocrine tumors, then the results have not been that encouraging as of yet. We did one study with Pembrolizumab, Keytruda. Many of you may be familiar with this drug from television commercials, for example. It's a PD-1 inhibitor. In well-differentiated gastroenteropancreatic and lung neuroendocrine tumors, the response rate was very low. It was less than 5%. In other words, only 4 out of 107 patients had significant tumor shrinkage, which is not very high. There was another phase 2 study with a Novartis drug, PDR001, that looked at different groups of well-differentiated neuroendocrine tumors as well as poorly differentiated neuroendocrine carcinomas, and also showed relatively low response rates. Perhaps with one exception, there was a little bit of a higher response rate in the lung neuroendocrine tumors, the thoracic cohort. Not extremely high, but higher than what we saw in pancreatic or gastrointestinal neuroendocrine tumors. There was a small phase 2 study, actually several now, looking at poorly differentiated neuroendocrine cancers. Again, a population where we haven't had too many studies, but the response rate with Pembrolizumab by itself was very low. It was only one response out of 29 patients when we combined 2 trials. So this drug by itself, Pembrolizumab by itself, doesn't seem to work too well. Now, recently there was a combination study looking at 2 immunotherapy drugs in combination, Ipilimumab and Nivolumab. They target those 2 ligands receptors I talked about, CTLA4 and PD-1. This was a so-called basket study. It was looking at a bunch of different cancers, but it included 2 neuroendocrine cohorts that weren't very well defined. One called endocrine carcinomas of the pancreas and gastrointestinal tract. Another just said neuroendocrine carcinoma, including carcinoma of the lung. So the eligibility was a little bit ill-defined for this trial, and it was a mix of neuroendocrine, well-differentiated and poorly differentiated neuroendocrine cancers. But when they decided to look just at the poorly differentiated neuroendocrine carcinomas, of which there were 19 patients, they saw 8 responders, which is relatively high. This was not a pre-planned analysis. It was a post hoc analysis. In the well-differentiated tumors, there were no responses. So it's very preliminary evidence of efficacy in this population. It generated a lot of excitement, including in patient groups. but it's very, very early. The study has since accrued a lot more patients, and now we're waiting for the more mature results. But perhaps this combination will work. Now, it can be quite risky to combine two immunotherapy drugs because the side effect of neuroendocrine regimens are autoimmune reactions, where the immune system basically targets normal tissue, and it can affect any organ. It can affect the gastrointestinal tract, causing severe diarrhea. It can affect the lungs, causing lung damage, the liver, causing liver damage, skin, causing rash. And we see that a lot more with two drug combinations versus just one drug. So we have to carefully consider risk versus benefit. So again, switching to a completely different trial, the GEP-NET trial is looking at liver embolization, hepatic arterial embolization, which is a technique that many of you are familiar with for patients with liver-dominant metastases. Basically, what the technique is, an interventional radiologist threads a catheter through the groin, accesses the artery supplying the liver, and infuses microparticles to block the blood supply to tumors. Now, when it's just microparticles, it's called bland embolization. When it's combined with chemo, it's called chemoembolization. And there's also a third type called drug-eluting beads that are basically chemotherapy-impregnated beads that are delivered to the tumor. Now, for decades, we've had interventional radiologists using any of these techniques based on their personal preference with absolutely no data to compare them. So this is a randomized trial comparing these three different techniques. And we're still waiting for the final results, but one thing we found out on interim analysis is that the drug-eluting beads can be quite dangerous for patients with neuroendocrine tumors. There was an unacceptable rate of toxicity. So that arm of the study was eliminated. So if anyone is considering a liver embolization, please don't do drug-eluting beads. But as far as bland embolization versus chemoembolization, we're still waiting for the results of the study. So I hope I've given everyone a little bit of a flavor of what the major studies there are that are currently accruing patients. There's hundreds of additional studies, many of them small institutional studies. There are several, I think, important ones in development. One looking at PRRT with Lutathera versus CAP-TEM in pancreatic NETs. Another looking at lutetium dotatate Lutathera in lung NETs, which is an area where it's not yet been FDA approved. Another important study being proposed is looking at capecitabine temozolomide as an adjuvant therapy after surgery for resected pancreatic neuroendocrine tumors. This will be one of the first adjuvant trials we've ever had in the neuroendocrine field, and if it's completed successfully, it'll be the first successfully completed trial in this space. And the goal is to see whether this chemo combination can reduce the risk of recurrence after surgery, potentially curative surgery. So again, I want to end this talk by emphasizing that the only way we can expand treatment options and advance the field is through patients participating in clinical trials. And I can't say how grateful I am for patients that I've seen who've been involved in clinical trials and who've really contributed, in many cases heroically, to the advances we've already made. And I know that many trials require a big commitment of time and effort. And I'm sure, on behalf of myself, all the other physicians in the field, we really appreciate it. So I'm going to stop here and hopefully be able to answer some questions. Are all placebo trials 50-50? So the question was, are all placebo trials 50-50, or are there some where only a few are on placebo? The answer is most placebo trials are 50-50. There are some that have a 2-to-1 ratio in favor of the active investigational drug versus placebo. Those are basically the two types. There aren't any studies where there are just a few patients on placebo. The reason being that the closer you get to 50-50, the easier it is to generate statistically significant results. If you only have a few patients on placebo, the statistics completely won't work. There won't be any way of proving that the drug actually works compared to placebo. And are there any clinical trials specifically related to carcinoid nets that are close to FDA approval? So when I said, so throughout this talk, and maybe I should have defined it more clearly, traditionally we often use the word carcinoid tumor for gastrointestinal and lung nets. I hope everyone understood that that's synonymous. We're trying to basically get away from use of the word carcinoid tumor and use the word gastrointestinal or lung net or pancreatic net, which is more precise. Close to approval, I would say nothing that I can think of right now that's close to approval. Nothing that's been submitted for approval. Maybe Axitinib will be the next drug if the phase 3 study is positive. And I should say I'm not really sure what's going on with Surufatinib. As I said, that's a positive phase 3 study. That's the latest positive phase 3 study we've seen, but it took place exclusively in a Chinese population, and their mix of neuroendocrine tumors is different from ours. For example, they almost in Asia they have very few midgut, small bowel neuroendocrine tumors, and virtually no patients with carcinoid syndrome. They have lung nets, they have rectal neuroendocrine tumors. So it's a different population, and I'm not sure how the FDA is going to handle that, frankly. Let's see, another question is, how do you get into a study? That's a good question. So basically, you have to see a doctor that has a study available at their institution. And the institutions that tend to have neuroendocrine tumor studies are typically large academic institutions that see a lot of neuroendocrine tumor patients, but that's not exclusively. I mean, occasionally community oncologists, like, for example, in Florida, cancer specialists will have neuroendocrine tumor studies. So it's not exclusively an academic trial, academic center kind of thing. I'm sure that the patient organizations all have a list of clinical trial studies and perhaps can point patients to academic centers. And there is a website called clinicaltrials.gov where you can enter keywords, but it gets quite tricky because the eligibility criteria are quite specific. So patients often are under the impression that they have 50 studies that they're eligible for, and in many cases the number is quite much smaller. And of course, you can always call the center and ask to speak to the clinical trial department, and the person there may be able to help you. Let's see if there are any other questions. Moffitt had once started a trial of the NET test. Was it completed? So with respect to the NET test, this is a test that looks at RNA expression of neuroendocrine tumors. And this was basically a very specific test. It was basically designed to answer the sensitivity versus specificity. What we found is that the NET test is very sensitive. In other words, patients with neuroendocrine tumors, the NET test is typically positive with few exceptions. And it was quite specific at distinguishing neuroendocrine tumor patients versus healthy patients. It wasn't completely specific comparing to patients with other types of cancer. It was a fairly small study. As far as figuring out how useful the NET test is in practical assessment of patient progression, patient tumor volume, et cetera, this trial was not designed to do that. Are there any other questions? Yeah, so the question was regarding the drug-eluting beads. Does that include Y90? The answer is no. This was looking at chemotherapy, chemotherapy beads, basically. The Y90 beads, which is a radioactive embolization, was not part of this particular study. I can say that there's been accumulating experience with Y90 that suggests that in patients who are treated in both lobes of the liver with relatively high tumor burden, overall, when we look at long-term follow-up, there are some cases where patients can develop liver fibrosis in a condition that sort of mimics cirrhosis of the liver. So we are increasingly seeing some concerns with routine use of Y90 embolization. We still do use it for some patients in some particular cases where we think it's better than bland embolization. But we have very few good prospective clinical studies with Y90 or for that matter with any other embolization modalities.